Hello. So today we'll talk about Guillain-Barré syndrome. This one is an interesting one because it's one of the neurological conditions that present with very fast paralysis. It's acute, usually presenting in 1 or 2 weeks. So it's scary once it happens because one day you're walking, the next day you have problems breathing because your respiratory muscles have become paralyzed. Starting from the leg upwards, everything goes. So it's quite a fast progression, and as we'll discuss more, we'll talk about how it works, and also that in the end it's not that bad because the prognosis is quite good. So these are the objectives as usual. We'll define what Guillain-Barré is. We'll talk a bit about its distribution amongst the population, what causes it, the mechanics of the disease, how it presents clinically, signs and symptoms, the different variants of Guillain-Barré, how we investigate and how we make a clinical diagnosis, its management and its outcome. So the definition is an autoimmune demyelinating neuropathy that usually affects peripheral nerves. So we learn a few things in the definition. It's autoimmune. It means it's your own body antibodies attacking the nerve cells. And it's demyelinating means it affects the myelin sheath, the one that insulates the neurons. That's the one that's affected, and mainly peripheral nerves. But as we'll see later, even some of the cranial nerves are affected. And is the most common cause of acute flaccid paralysis worldwide. Acute flaccid paralysis means it happens very quickly, and flaccid means your limbs are all loose. They are very weak and loose. You can't move them. It's different from spastic paralysis. There are two types of paralysis. There is spastic and there is flaccid. In spastic, you can move your arms and legs. However, when someone tries to move them, it's very stiff. You can't flex, you can't extend. But in flaccid, it's very loose. It's like it just falls down. So the epidemiology is very rare. You don't see that often, and it usually affects Caucasians, and males are affected more than females. This is it's one of the few autoimmune diseases where males are affected more. Usually, the rule of thumb is that females usually get the short stick when it comes to autoimmune diseases. So these are the causes. Influenza vaccine, it's not there's nothing to worry about. The influenza vaccine won't cause Guillain-Barré except in 1 in a million cases. It's very rare. More common ones are the virus itself, the influenza virus, and even more commonly, it's some GI infections like Campylobacter jejuni. In fact, that's the most common cause of Guillain-Barré. So these things happen. You can have a GI infection. You can have usually Campylobacter jejuni presents with watery diarrhea, sometimes bloody, and then within 1 to 6 weeks of the onset of the diarrhea, you present with Guillain-Barré. So it's an autoimmune reactions I'll talk about later. But whenever you see a patient with Guillain-Barré, just ask or make sure you have the antecedent infection in mind. Antecedent means the infection prior to whatever the child is presenting with now. So Guillain-Barré, but then ask whether the patient had any respiratory infection or GI infection a few weeks back, usually 1 to 6 weeks, and then you present with Guillain-Barré. Surgery and trauma. These molecules, trauma to the body produces some molecules called HSP70, which trigger the immune reaction that leads to Guillain-Barré. You can read more on that. There's a bit of details you can get in some articles, but basically one of the most common one is the GI, the Campylobacter jejuni infection. So pathophysiology, it's molecular mimicry. What this means, in a nutshell, it means that when you get a foreign body infection, a bacteria, virus, whatever, so the body, how it reacts, it produces antibodies that attacks the bacteria and the virus. So molecular mimicry means the proteins in the bacteria or in the virus are similar to some of the proteins found in some of your tissues. So instead of your antibodies attacking the bacteria, they end up attacking a similar thing, which is your tissues, your own tissues. So it's autoimmune. So in this case, the lipopolysaccharide of the Campylobacter jejuni resembles the gangliosides of nerve cells. So there's cross action. So your antibodies attack the gangliosides, which are the myelin sheaths of the neurons. So They attack different parts of the neurons. As we know, the structure of a neuron, we have a dendrite towards the end. No, we have a dendrite towards the beginning, and we have the neuromuscular junction towards the end, and then we have an axon in the middle. The axon is covered by myelin. So these various antibodies, anti-GD1A, anti-GM1, and anti-GQ1B, they attack different parts of the neuron. So anti-GM is the one that attacks the neuromuscular junction. Because it's attacking the neuromuscular junction, you usually have weakness, the motor weakness. You can't move. And GD1A usually it's found in the nodes of Ranvier, which are disruptions in the myelin sheath where the nerve conduction, the action potential across the nerves. So it's sensory. So when you have GD1A attacking the nodes of Ranvier, you'll have a sensory loss. So you can't feel your legs. You have hyporeflexia. GM1, you have neuromuscular weakness. GQ1B is, we'll see it in a specific type of Guillain-Barré, which is Miller Fisher, which has its own specific manifestations. So clinical presentation, as I said, acute onset paralysis, which means quick. Usually when you have a tumor, when you have some degenerative conditions, it starts slowly. But in strokes and in this condition is very acute. And in stroke, it's spastic paralysis. As I said earlier, your limbs are stiff. But in Guillain-Barré, it's flaccid paralysis. And it's ascending. This is very important, and it can make you catch the diagnosis quickly. So the paralysis is ascending. So if it starts in the limbs, it'll start from the lower limb and then go upwards. And it's also distal to proximal. If it starts in your hand, you start with your fingers first and then move towards the shoulder. It's also symmetrical because of the way the antibodies work. So if your right leg is affected, your left leg will also be affected the same way. It's not unlike stroke where you can have one-sided paralysis. In Guillain-Barré, both of them will ascend together. There is also acroparesthesia. So the paralysis is because of the neuromuscular junction being affected, and the paresthesia is because of the nodes of Ranvier. So you have a pins and needle sensation and can progress to loss of vibratory sense, touch, and proprioception. Now, the thing to worry about in Guillain-Barré is when the paralysis ascends to the diaphragm. The diaphragm is it's a muscle that's used for breathing. So when the diaphragm gets paralyzed, your breathing is compromised. So you have respiratory failure, and these are one of the few neurological emergencies for which you need to intubate the patient and take him to ICU. So these are peripheral nerves. As I said, Guillain-Barré mainly affects the peripheral nerves. However, it can also affect the autonomic nerves. So these are the autonomic neuropathies. So if it affects the blood vessels, so the pressure will go up and down, and the main presentation is orthostatic hypotension, which means when you stand up, your pressure goes significantly down and may cause dizziness. Cardiac arrhythmias and urinary retention, one of the autonomic neuropathies. So we have other less common presentations. As I said, peripheral nerves is the most common. It can also affect cranial nerves. If it affects the vagus, it will cause dysphagia, which means you can't swallow food. Facial nerve palsy, encephalitis. It can even attack the brain. This is specific. It's called Bickerstaff encephalitis. And neurogenic pulmonary edema. As we said, if the diaphragm is affected, it's paralyzed. It won't do the work of breathing. Even the intercostal muscles can be affected. So because the chest cavity is not moving in and out, up and down, the lungs are also not inflating and deflating. So there's fluid buildup. That's neurogenic pulmonary edema. As I mentioned earlier, we have variants of Guillain-Barré. Let me start with the one that's common, which is the second one, the acute inflammatory demyelinating polyneuropathy. That's the one that we usually see. And when you do the nerve conduction test, it will come with a partial nerve conduction block, mainly the motor one. Now, as I talked about the antibodies, the anti-GM1, anti-GQ1B, and anti-GDA1. So the anti-GQ1B is specific because the condition that it causes is Miller-Fisher syndrome. Now, the easiest way to remember Miller-Fisher is the three A's: acute ophthalmoplegia, ataxia, areflexia. So it's acute ophthalmoplegia, areflexia, and ataxia. So as you've noticed, as I said, anti-GQ1B. So it will not cause motor weakness. You'll be able to move your legs well, only that your reflexes will be compromised. That means it has a sensory component. Now, I've talked about the second one. The third one is the pharyngeal cervical branchial variant. This one will only affect the muscles of the things I've mentioned: pharynx, the neck, and the upper body, a bit of the upper chest, but mainly around the neck region. That's Those are the muscles that have paralysis. Now, acute motor axonal neuropathy, from just the name acute motor, so it's anti-GM1, the neuromuscular junction that's affected. So we have motor weakness, paralysis. You can't move your legs, you can't move your hands. However, the reflexes are normal. And the second is just a severe form of the first. It's affecting the motor and the sensory one. And among the fourth one, it's more common in Asian populations. So the diagnosis is a clinical one. You can diagnose Guillain-Barré just from the clinical setting and then start initiate management. So there are four clinical criteria to diagnose Guillain-Barré. So as I say, it's progressive symmetrical paralysis of more than one limb. So it has to be progressive, meaning ascending downwards to upwards. Hyporeflexia or areflexia, and because it's acute, the progression should be within 1 month and symmetrical. As we've seen with the variants, this can be, not all variants will present this way, but the most common one will present this way. So the classic Guillain-Barré, these four things you should look out for in diagnosis. And then you can do some tests. The main one will be the lumbar puncture. And the classical presentation in lumbar puncture is albuminocytologic dissociation. What this means, albumin cytologic. So albumin is protein. So in CSF, you'll have elevated proteins. However, the cytology will be normal. That means the white blood cell count, all the counts, white blood cell, red blood, everything will be normal in the CSF. Only the albumin will be high, which is different from if there was a meningitis where we will have high protein as well as high white blood cell count. But in Guillain-Barré, you'll have high protein and normal white blood cell count. You can also do the electromyography and the nerve conduction tests. So management is mainly supportive. Guillain-Barré will automatically resolve within 4 to 6 weeks of onset. It's not that worrying. The main problem with Guillain-Barré is respiratory failure when it affects the diaphragm, the neurological emergency I talked about. So when the neurological emergency happens, you have to take the patient to ICU and intubate so that the patient can breathe using a ventilator. And for treatment, you can start IV immunoglobulins because it's an autoimmune condition. You have your own antibodies attacking your body. So IVIG will now stop those antibodies. So it's best started within 2 weeks of onset. That's when its action is optimal. Plasmapheresis is basically running your blood through a machine where the antibodies will be filtered out. And finally, prognosis is good. It's nothing to worry about. 85% will recover without any significant morbidities. Only 15 to 20% will have some permanent neurological disabilities. Thank you.